Hi, good morning, everybody. And where is the evening? Good evening. I am Dr. Mohammed Kazafi. You are watching Dr. Mohammed Kazafi Views, and I want to begin with a topic. Actually, it is a very, we can say, the most common tumor of the central nervous system, and then I will try to explain specifically for the brainstem. But right now, I want to present here. This is the glioma, and this glioma is a glioma. You know that there is a most common form of the central nervous system, a neoplasm that originate from the glial cell. In the United States, there are the 6 cases of the glioma diagnosed per 100,000 people every year. And the gliomas are the very diffusely infiltrative tumors that affect the surrounding brain tissue. And the glioblastoma is the most malignant type, while the pleocytic astrocytoma are the least malignant brain tumor. And this activity I want to show here the different type of the gliomas and the pathophysiology of the gliomas definitely. And then I want to summarize the treatment of the glioma here. Glioma is the most common form of the central nervous system neoplasm, and that originate from the glial cell in the United States, and there are 6 cases of gliomas diagnosed per 100,000 people every year. Gliomas are very diffusely infiltrative tumors that affect the surrounding brain tissue, and the glioblastoma is the most malignant type, while pleocytic astrocytoma are the least malignant brain tumor. In the past, these diffuse gliomas were classified into different subtypes and grades, and based on the histopathology such as the diffuse astrocytoma, oligodendroglioma, and mixed glioma or astrocytomas. Recently, the gliomas were classified based on the molecular and the genetic markers. So these advances have more specific prognostic and therapeutic benefits for patients with gliomas. In addition to molecular and genetic marker, gliomas are classified in grade 1 to grade 4 based on the degree of the proliferation and medicated by the mitotic index and presence or absence of necrosis. Regarding the etiology, there are 3 common types of gliomas which are classified based on the phenotypic cell characteristic astrocytoma, ependymoma, and oligodendroglioma. These cell gliomas are further classified into the low-grade glioma, atypical, and the high-grade tumor based on the cell morphology, mitotic activities, and molecular markers. The World Health Organization grading system utilized molecular markers that have shown to have significant prognostic and therapeutic implications. Astrocytomas, originate from the astrocytes, and that can encapsulate preserved clear borders between the normal and the tumor cell, or infiltrative, indicating advanced grade, low grade are common in children, while high grades are common in young adults and older patients. Oligodendrogliomas originate from the oligodendrocyte cells, and these are less infiltrative than the astrocytoma and are common in adults. Ependymomas originate from the ependymal cell, which are found lining the ventricular cavities and the central canal of the spinal cord, and these are common in pediatric patient population. These are estimated roughly of 80,000 newly diagnosed cases of the primary brain tumor each year only in United States. and around one-fourth of which is, you can say, the 20% are the, or we can say there are the 20,000 are gliomas, and the total number of the glioblastoma diagnosed each year is about 12,000, approximately 15% of the total newly diagnosed brain tumor. Headaches are the most common initial presenting symptom of patient with gliomas, and the pathophysiology of headache is theorized to be the result of the tumor growth and that plays a mass effect on surrounding tissue. The mass effect in turn lead to pressure in the microvasculature and lead to edema, and depending on the location of the tumor in the brain, the mass effect lead to sign of a brain tumor. For example, frontal lobe tumors can present with the behavioral changes, while dominant temporal lobe tumor can present with the receptive speech problems, and the other symptoms related to the mass effect include nausea, vomiting, and change in vision. So the seizures are the second most common symptom of the presentation, and the pathophysiology of the seizure is attributed to the tumor irritation to the cerebral cortex that lead to the focal or generalized seizures, and other presenting symptoms of gliomas are tingling sensation, weakness, and difficulty ambulation, and in a rare case, patient can present in a comatose state due to the hemorrhage within the tumor, which lead to an acute herniation syndrome. Toxicokinetic, if I consider, there are some epidemiological studies suggesting that the ionizing radiation and some radiofrequency wave can increase the chance of the redeveloping high-grade glioma. However, these studies lack specificity to glioma, and however, advances in the molecular biology and genetic of the gliomas have revealed that the low-grade glioma transform into the high-grade glioma by altering the genetic makeup of low-grade gliomas. Therefore, one can hypothesize there is a environmental and treatment-related cytokinetics can help or can play to role in the transformation of the low-grade gliomas into the high-grade gliomas. The most common presentation in brain gliomas are the headache, nausea, vomiting, seizures, and in more advanced cases, weakness or altered mental status. The neurological examination of these patients can be normal or present different degree of the focal weakness, sensory deficit, or in a severe situation, altered mental status due to an acute mass effect result from the tumor swelling. The following imaging diagnoses are appropriate in the setting of the history and the physical examination suggestive of brain tumor. So, the computerized tomography CT scan, a good study should be done to evaluate acute intracranial findings such as the hemorrhage, edema, and asymmetry in the brain tissue. So the computerized tomography definitely is a good study to be done to evaluate these intracranial findings. But magnetic resonance imaging of the brain, this is the sensitive study to determine the characteristics of the brain tumor. Low-grade tumor usually do not enhance, while the high-grade tumors have a different degree of enhancement. And in addition, MRI is a great study to evaluate the degree of the cerebral edema. An MRI study of the brain will facilitate the treatment plan and response to the surgical radiation and chemotherapy. Chest X-ray, patient newly diagnosed with the brain tumor need an appropriate metastatic workup based on the patient's history and physical examination. For example, patient with an extensive history of the tobacco use might require a chest X-ray, and if there is any finding of a mass on the chest X-ray, it needs to be investigated using a CT scan of the body or the positron emission tomography scan to identify the potential primary source for the metastatic disease. So that's why patient chest X-ray is definitely for the metastatic disease, and diagnosed with the brain tumor and appropriate metastatic workup we can do. Treatment management, the WHO classification of gliomas is used to guide glioma treatment. As indicated in the classification, most patients require surgical intervention via gross total resection or biopsy. So the WHO grade of the glioma, the diffuse, astrocytic, and oligodendroglial tumors. Diffuse astrocytoma, IDH mutant, and the anaplastic astrocytoma. If we say the diffuse astrocytoma or the diffuse astrocytic and the oligodendroglial tumors, from them the one type is diffuse astrocytoma, and it is IDH mutant is the grade 2, and the anaplastic astrocytoma IDH mutant grade 3, and the glioblastoma is a wild type and it is grade 4, and the glioblastoma other one, which is the more oligodendroglial element, is more, so then also it is a grade 4, and the oligodendroglioma only, which is considered in the grade 2, and the anaplastic oligodendroglioma, which is mixed in the grade 2 and grade 3, but more in the grade 3. So the astrocytic tumors such as the pleocytic astrocytoma, which is the grade 1, and the subependymal giant cell astrocytoma, also the grade 1, and the pleomorphic xanthoastrocytoma, this is in grade 2, and the anaplastic pleomorphic xanthoastrocytoma, it is coming in the grade 3. If I talk about the ependymal tumors, so the ependymal tumors are the subependymoma is a grade 1, myxopapillary ependymoma also in the grade 1, ependymoma considered in the grade 2, ependymoma fusion positive, which could be in the grade 2 or grade 3, but anaplastic ependymoma definitely will come in grade 3. Other gliomas such as the angiocentric gliomas, which is come in the grade 1, and choroidoid glioma of the third ventricle, which comes in the grade 2. So treatment of the glioma, definitely the surgery is an option, or we can say the major option. So the grade 1, these tumors are surgically curable. Grade 2, a safe gross total resection and radiographic follow-up are acceptable current practice. And the grade 3, a safe gross total resection concomitant, we can say the chemoradiation and the chemographic follow-up for the recurrence are an anaplastic treatment. Grade 4, glioblastoma, a safe gross total resection if possible, then concomitant chemoradiation and the radiographic follow-up for the recurrence are in an acceptable treatment. So the way of treating the grade 3 and grade 4 almost the same, but grade 3 results are better as compared to the grade 4. Because in grade 3 and grade 4, we are trying to do the gross total resection associated or concomitant with the chemoradiation, and then radiographic follow-up for the recurrence, and it is an acceptable treatment. Chemoradiation currently STIP protocol is a standard of care for the grade 3 and grade 4 gliomas, and the protocol consists of the radiotherapy and concomitant chemoradiation using a total of 60 gray to 2 gray per daily fraction over 6 weeks, and temozolomide. Temozolomide is an important part of the chemoradiation treatment, and STIP protocol included it, and it is a standard care for the grade 3 and grade 4 gliomas, and the protocol consists of the radiotherapy and concomitant chemoradiation using a total of 60 gray to 2 gray per daily fraction over 6 weeks with the temozolomide. So treatment for recurrence, option for recurrent gliomas include reoperation with the gliadal wafer and targeted therapies such as the angiogenesis inhibitor or immunotherapy, and the effectiveness of all these adjuvant therapies is in development. Other treatments such as the high-grade gliomas, patients are prone to seizures, malignant edema, and the complication related to the immobility. Therefore, these patients need the anti-epileptic medication, deep venous thrombosis, prophylaxis, DVT prophylaxis, and the steroid before, during, and after the course of the treatment to avoid the cerebral edema. So this is in the high-grade glioma, we have to take care for the seizures or the malignant edema and the complication related to the immobility, and then these anti-epileptic medication associated with the, or apart from that, deep vein thrombosis prophylaxis medicine and the steroid, we have to take care. Here, differential diagnosis, when you are considering the glioma, it could be abscess, it could be demyelination, it could be the only gliosis, it could be infarction, or it could be metastasis. Regarding the prognosis of the glioma, it is not a straightforward answer, and it is the age of the patient, comorbidities, grade, and the location of the tumor, then the presence of the hydrocephalus, response to adjuvant therapies, and the extent of the surgical resection. All are the important part and playing important role to understand the prognosis of the gliomas. If we consider regarding the major complications, it is causing increased intracranial pressure because this is the additional space of and they are occupying the additional space, and the seizures, hydrocephalus, brain herniation, hemorrhage into the tumor, locally spread, spinal metastasis, death. So the patient should be educated on the importance of the regular follow-up visits and having medication on time, and regarding driving restrictions. And the patient with the glioma require an interprofessional treatment approach such as the neurosurgeon, neuro-oncologist, radiation oncologist, and other professionals. But the glioma in general, specifically glioblastoma, are very difficult to treat despite advancement in the medical field nowadays. And in understanding of the molecular biology and the genetics of the glioma, no significant impact has been made towards preventing the, we can say, the lethality of the high-grade glioma. Therefore, there is a continued need for the clinical and the basic science investigation to avoid any advancement of the lethal response of this lethal disease. Actually, I wanted to introduce with you the glioma. Now I introduce the glioma. Now I want to come to the topic which is I wanted to present here, and this is diffuse intrinsic Pontine glioma. This was the topic of choice what I wanted to present in front of you. Or specifically I wanted to present in front of you the glial tumor or any glial tumor of the brainstem. So before going further, I want to show you one picture or few pictures in front of you. So friends, actually I wanted to present this picture in front of you people. Definitely I gave the lecture, or maybe it is not pictorial initially, but now I want to present this thing in front of you. You can see the brain tumors. Actually we are interested in the to present the gliomas, but here when you are seeing that this is a brain tumor and I want to present in front of you, so you can see there is where is the location most likely. If you consider there is a pileocytic astrocytoma tumor of the cerebral hemisphere, and which is the high grade gliomas including the glioblastoma. These are the primary, we can say, the neuroectodermal or the primary neuroectodermal tumor. These all tumors you can see in the, definitely you can see in the frontoparietal area, you can see, and oligodendroglioma you can see it is mostly in the parietal area. Optic gliomas are also important to know, and when the chance will come, I will try to present this. You can see there is the optic glioma here. Definitely, I have made a little introduction for the glioma initially, so anybody can understand what is glioma. Definitely, a lot of people know, but it is a humble reminder for them. And now you can see there the brainstem glioma I want to present now. And especially I took the Pontine area for that, and then definitely when I talk about the Pontine, then definitely I will talk about more specifically functions of the Pontine or the these things which will means understandable for everybody. Definitely spinal ependymomas, it is a part of the gliomas, and the infratentorial ependymomas also the part of the gliomas, cerebellar astrocytoma also the part of the glioma, and the tumors of the cerebellum such as the pileocytic astrocytoma or medulloblastoma, they are definitely are part of the glioma. And here the you can see the supratentorial ependymoma part of the glioma, and you can see the pileocytic astrocytoma involving in the we can say more central area of the, or we can say the lateral wall of the lateral ventricles, and they are also the, so the pileocytic astrocytoma you can see here, you can find everywhere in the brainstem, in the cerebellum, in the central nervous system, means in the more central area of the brain, more eloquent area, and the cortical area. So this picture almost explained you a lot of things, and you could understand a lot of things here. In the same manner, before jumping towards the brainstem tumor or the brainstem glioma or the Pontine glioma, I want to show you this picture is telling maybe more than 1,000 words, and you can see in the frontal lobe, you can see they are showing there is a possibility of the glioblastoma multiforme, oligodendroglioma, oligoastrocytoma, and then in the basal ganglia or lateral to the lateral ventricle area, which I mentioned before, which is basal ganglia, and here you can see the astrocytoma. In the optic chiasma, definitely not in, but in when you saw the optic area, then it is the optic gliomas there, and you can appreciate the, if you go to the midbrain pons and the medulla oblongata, then you will find here the astrocytoma, and the brain, and in the cerebellum you can appreciate the medulloblastoma. So these all are tumors, just to show you a pictorial memory for you people. If you want to understand this, then you can understand this, how the tumors are scattered, and specifically the glioma how behave. So in this specific picture, you can see there is a gliomas, and how the gliomas, when they are in the parenchymal area, and you can see in the T2 weighted image there is a hyperintensity signals, and in T1 weighted image you can see the hypointensity signals, and in contrast you can see there is a not taking too much contrast. So maybe if not taking too much contrast, maybe it is a low grade glioma, but we cannot promise for that, but it could be, I'm telling, could be the low grade glioma. So this is the picture of the gliomas, and now you can understand how gliomas are behaved. Now I want to come to the topic which I am going to present, and this is you can appreciate there is a brainstem glioma, and in this picture you can appreciate there is a T2 weighted image MRI axial, and T1 weighted image MRI axial. Both are presenting differently the tumor. In T1 more of a ISO and the little hyper intense, but in the T2 weighted image you can appreciate the hyper intense, more hyper intense area and the less ISO intense area. So these are the details of the detailed picture of the Pontine glioma or the brain tumor. Now I am going to present this case, and then I will try to present a case which is with the anomaly, and then you can appreciate this thing. I hope you will like it. So the diffuse intrinsic pontine glioma is an aggressive type of childhood cancer that forms in the brainstem, and they are very rare, almost always occur in the pediatric population. To avoid the high morbidity and the mortality associated with this condition, diffuse intrinsic pontine gliomas must be promptly diagnosed and treated immediately. And this activity review the evaluation and the treatment of the diffuse intrinsic pontine glioma. So diffuse, as I mentioned, the diffuse intrinsic pontine glioma, they are the rare pediatric brain tumors, and they are not as common. Thank God it is not too much common. So patient are less people are suffering with this, and we can say the lethal disease is a really a significant problem, and almost always affect the pediatric population, with approximately 200 to 300 new annual cases only in United States, and the most patients survive less than a year. So these patients were primarily treated with the radiation therapy, as surgical resection was not a viable option for them, and the effect of the radiation therapy are temporary, and no chemotherapeutic agent has been effective in treating this pathology. So the several clinical trials of new agents, or we can say the novel therapeutic approach, have emerged over the past decade to improve the outcome of the patient with, we can say, the diffuse intrinsic pontine glioma. So the formation of this tumor may be linked to the brain development, and studies suggest that the disease process is created by particular cell and that exists in a very high concentration. while the cerebral tissue is developing, and the theory is supported by a fact that the tumor rarely occur in adult and almost always occur in the mid-childhood, age 5 to 10, in period in which the cerebral tissue is very active in development. So the model was identified, the neuronal precursor like the cell population on the normal human ventral pons that is linked both anatomically and temporally to the incidence of the diffuse intrinsic pontine glioma. The frequency of the cell type during mid-childhood mirrors the bell-shaped incidence curve of the diffuse intrinsic pontine glioma. These cells are notably absent in the midbrain, and the diffuse intrinsic pontine glioma are virtually non-existent. So, on the molecular level, recent advances in the biological understanding of the disease have identified the H3K27M mutation is nearly 80% of the diffuse intrinsic pontine glioma. And if we are considering on 2016 World Health Organization classification of diffuse midline glioma mutant, a grade 4 brainstem tumors. So the brainstem glioma affect approximately 300 children only in the United States each year, and the major cause of death in children with that brain tumor. So the most common of these is a diffuse intrinsic pontine glioma and comprises 80% of the cases, and the incidence is 1 to 2 cases per 100,000 population, and diffuse intrinsic pontine glioma has a peak incidence of 6 to 9 years, and the slight preference of the male, and among all the tumor in children they present 20% of the. So one of the most accepted theories of the development of the diffuse intrinsic pontine glioma is a mutation in the H3 gene, and mutation in the N-terminal tail of the histone H3 gene has been recently found in the midline, or we can say the pontine high-grade gliomas, and are high frequency in the diffuse intrinsic pontine gliomas. For that substitution of the lysine at the position 27 of the H3 encoding gene in the driving force behind the diffuse intrinsic pontine glioma oncogenesis, and it is implied there the whichever history or whatever the history, H3 variant is targeted by the mutation H31, H32, H33, so may lead at the development of the diffuse intrinsic pontine gliomas. The H3K27 mutation and the loss of the H3K27 mutation 3 are of the paramount importance, since it is the characteristic of the diffuse intrinsic pontine glioma and likely present with the first genomic event leading to transformation in these tumors, and these diffuse intrinsic pontine glioma thus appear as a homogeneous tumor group defined as the glial neoplasm with a stereotypically genetic drive consecutive of the histone H3 mutation. As you know, the diffuse intrinsic pontine gliomas belongs to the fibrillary astrocytoma family, and most lesions are WHO grade 3 and grade 4. So very few cases are WHO grade 2, but they act similar to the high grade cases, and the disparity between the histological grading and clinical outcome may be overcome by using molecular features in the tumoral cell. Microscopically diffuse intrinsic pontine glioma infiltrate gray and white matter structure, and the tumor cells are generally small and monomorphic, but sometimes can be large and pleomorphic. So they typically have an astrocytic morphology, although oligodendroglial morphology is also a recognized pattern, and the majority of the tumor have mitotic figures, so the microvascular proliferation and necrosis. About 10% of the diffuse intrinsic pontine glioma lack mitotic figures and microvascular proliferation. Thus, they are histologically consistent with WHO grade 2. So, this pleomorphism, mitotic figures, microvascular proliferation, all are very important to understand, and we can understand the grade of the glioma accordingly. That's why it is very important for the treatment, and when we are estimating the prognosis of the patient, specifically when the definitely family wanted to know and how our children will go on or carry on. Regarding the evaluation, the magnetic resonance imaging of the brain with and without contrast is the most diagnostic or the best diagnostic study to evaluate a patient with a suspected diffuse intrinsic pontine glioma. Usually more than half of the enlarged ventral pons will show an increased signal on the T2 FLAIR MRI sequence, and the tumor will not show contrast enhancement, but occasionally a small area of the necrosis can enhance, and that the higher value on the apparent diffuse coefficient derived from the diffuse weighted MRI images correlate with the better median survival. And MRI brain will assess leptomeningeal tumor dissemination, and MRI of the entire spine is recommended to exclude the spinal bleeding or spinal seeding. And in patient without hydrocephalus, a lumbar puncture can be performed or cerebrospinal fluid analysis to evaluate for the tumoral cell and circulating tumor DNA and detecting the H3K27 mutation. So the treatment management here, the steroids significantly dexamethasone are given, and the goal of the treatment is the stabilization of the neurological symptom until possible neurosurgical biopsy or radiation therapy. So the complication due to the long-term use should be avoided, thus it should be weaned off as quickly as tolerated, and the steroid stabilize the blood-brain barrier and can affect tissue penetration of systemic therapies. And additionally, dexamethasone used in a high-grade glioma is associated with worse overall survival. So during the management, less than 10% of patients diagnosed with the diffuse intrinsic pontine glioma develop hydrocephalus and require a third ventriculostomy, or we can say the ventricular peritoneal or ventricular shunt. The most important step in management to obtain a tissue diagnosis, first it characterize the lesion for the classification and the treatment, and second it is used for the research and the development of the more effective management strategy. So nevertheless, there has been a historical resistance to the biopsy of these tumors, and because of the anatomical axis, fortunately the technology has advanced, and stereotactic biopsy is a safe, minimal invasive procedure that has a very low complication rate. And based on the literature, the stereotactic biopsy of the diffuse intrinsic pontine glioma is as safe and diagnostic as the supratentorial biopsy, and the amount of tissue in the biopsy allows for the analysis and include whole genome sequencing. So the radiation oncologists are consulted immediately after diagnosis diagnosed to plan the further treatment. So even though these has been the tremendous advancement in radiation and research in oncology recent days, but the outcome for the survival for the children with the diffuse intrinsic pontine glioma have not changed significantly over the past 20 years. So the conventionally fractionated radiotherapy is still the standard of care for the children with the diffuse intrinsic pontine glioma, but hypofractionated radiotherapy has shown promising results when compared with the conventional radiotherapy. That's why the radiotherapy is usually given to the tumor for the total dose of the 54 gyron for the 6 weeks, or we can say the 1.8 gyron daily fractionated fractions, and the hypofractionated radiation with 39 gyron using fewer fraction have similar outcomes, and it is better tolerated in the young patient. And the re-irradiation for the tumor progression can be considered with 25 gyron given over a 10 fractions, producing a mild symptom or a survival benefit, and the radiosensitizing agents do not improve survival. So the several clinical trials of the various systemic therapies include the stem cell transplantation, temozolomide, and gemcitabine or capecitabine or tyrosine kinase inhibitor have been tested, or we can say the tests are ongoing, and still none have proved to increase the survival of the children with diffuse intrinsic pontine glioma. And the conventional or the convection enhanced drug delivery system have brought hope to treatment of the diffuse intrinsic pontine glioma. So the improvement in the field may provide better drug delivery system and they target these tumor cells directly, especially at the normal brain tissue interface. A new therapy for the management of the diffuse intrinsic pontine glioma is adjuvant multimodal immunotherapy, and this therapy consists of vaccination cycle, which is called the Newcastle disease virus, or we can say the mature dendritic cells. These are given in a vaccination cycle as an immunotherapy, and these immunogenic cell death therapy, such as the temozolomide and the local modulated electrohyperthermia, offering improved overall survival but warrant further investigation. So here the differential diagnosis, when you are considering there the pontine glioma, it could be the midbrain glioma, it could be cervicomedullary glioma, it could be pilocytic astrocytoma, it could be the cavernoma or malformation, or it is a demyelinating disease, or it may be the infectious disease. The prognosis of the diffuse pontine intrinsic glioma is dismal due to the absence of the effective therapy, that a tumor is a principal cause of the death among brain tumor affecting the childhood. And the most patients are diagnosed before 7 years of age, and after diagnosis, median survival is usually 9 months. So only 10% live for more than 2 years. So when compared to the pediatric glioblastoma, the prognosis for the diffuse intrinsic pontine glioma is the worst, with the less overall survival rate. I know this topic is not very promising, containing very promising results, but definitely for the understanding point of view, I chose this topic and I wanted to present in front of you. The complications are definitely, like the disease, are worse, like the facial paralysis, dysphagia, respiratory insufficiency, hemiparesis, deep venous thrombosis, hydrocephalus, radiation necrosis, brain herniation, coma, surgical complications such as intracranial hemorrhage, edema, seizures, and the cranial nerve injuries. Here the people we need, definitely we whole bunch of the people we require, such as the neuro-oncologist, radiation oncologist, neuroradiologist, neurosurgeon, neurologist, neuropathologist, pediatric intensivist. So these all people are consulted and required to treat or try to manage these kind of people, even though the prognosis are worse than the glioblastoma. So patient with the diffuse intrinsic pontine glioma and the family member should have a complete understanding of the disease and the prognosis to have the realistic expectation and the timeline of the how early the patient is diagnosed will have an important part in how the family react to the situation. It is the way in the early phase, and then in my humble opinion, psychologists and the psychiatrists and the family therapists should form a part of the team for them and the realities of the deficits, physical impediment, or we can say the overall condition after treatment should be clearly explained to the parent. While the pediatrician is the almost always involved in the care of the patient, such as with the diffuse intrinsic pontine glioma, it is essential to consult with an interprofessional team for the specialty that includes the neurosurgeon, neuro-oncologist, radiation oncologist, and the nurses, of course. And the vital members of the interprofessional group are they monitor the patient and the vital sign and assist while the education of the patient and the family. So now I want to present one case for the analogy to give a better understanding for us here. So here we go. There is an 8-year-old boy experiencing several weeks of the difficulty playing, and upon closer history taking, he also complained of the difficulty watching TV with the picture becoming blurry, and his mother has also noticed that his eye don't seem to gather, and he has had the nausea for the past 3 days and has complained for a severe headache today, and his father brought him to the ER because of the pediatrician office is closed Saturday, and the ER obtained a CT scan showing a mixed density irregular mass in his brainstem. So the differential diagnosis for us, definitely there is a brainstem glioma, which is a subtype of the astrocytoma. Histopathology usually reveal fibrillary and the pleocytic type of the astrocytomas, or the cavernoma, or we can say the metastatic disease, or transverse myelitis. So definitely investigation has been done, all kind of investigation has been done. Patient has been admitted, and that MRI shows there the cyst may be seen with either the high or low grade form necrosis, and the hemorrhage within the mass can be noted in later stage and in malignant form. So the MRA and CT scan or the CT angiography can be useful to rule out the cavernoma, and the attention must be paid to the we can say to determine for the tumor is diffuse or focal, diffuse intrinsic, and we can say the pontine glioma is spread widely throughout the brainstem, and the focal tumor could potentially be the low grade or more amenable to a resection as compared to the solely a biopsy. So the further workup than the biopsy, and the exophytic component is present present that is safe to biopsy usually only in the focal glioma, and the diffuse intrinsic pontine glioma are generally not biopsied. So the CSF protein may be evaluated for the cautious during lumbar puncture as the hydrocephalus is generally present. But the pathophysiology here, the most of the astrocytoma in this location are the grade 3 and the grade 4, and even the grade 2 grows very rapidly, and the molecular analysis may aid in the treatment and therefore important to obtain tissue if it is safe to do so. So the treatment options definitely we have very limited and few, and the surgery definitely is there. But giving location of the tumor, surgery is not usually an option as a vital function, including the wakefulness and the breathing control are in this location. So the radiation is the most effective and the most common initial treatment therapy, and this is typically done over a 6 week period, and which is the standard agent chemotherapy or the experimental drug can be used to complement the treatment and the attempt to control the growth tumor. So there is a radio sensitizer drug that make tumor cells are more sensitive to the radiation therapy and can be used. So the molecular analysis of the tumor has been used to link the particular profile of the specific patient tumor to target the specific aberration found in that tumor. For example, the specific pediatric neuro-oncological, we can say the consortium opened such as a trial in 2013, and if the biopsy revealed a grade 1 brainstem glioma, a more aggressive resection on the MRI can be attempted and controlled with the radiotherapy for the remainder can be effective. But when there is a grade 2 or grade 3 or grade 4, then definitely there is the surgical technique or the surgical biopsy may be attempt to confirm the diagnosis, obtain tissue for the specialized chemotherapy protocol unique to each patient, and assist in making the patient eligible for the clinical trial, and they may be available. For patient can be placed in a prone or 3/4 lateral position. So the stereotactic imaging guidance registration should be performed because of the anatomy is severely distorted in these cases, and the standard anatomic landmark cannot be trusted. A small suboccipital craniotomy and the C1 laminectomy can be performed in a standard fashion, and the dura should be opened under the microscope, as a neurovascularization may be occur with these tumors. A judicious biopsy should be performed with the microbiopsy forceps, and we prefer to take biopsy from the junction of the cerebral peduncle and the lateral and the superior most aspect of the adjacent fourth ventricle. In our experience, the approach has the minimized complication in this area, and the dissection in advance with the discussion in advance with the neuro-oncologist and the pathologist should determine how much specimen is necessary and the preferred method of it being managed from the operating room en route to the pathology laboratory. And as the specimen here is usually not a large amount, and the permanent specimen may be preferred over the using tissue for the frozen section. So the need for the diagnosis based upon the frozen section to verify the presence of the tumor, and most of determined based upon the quantity of the tissue obtained and the amount required for the permanent section. So, as you know, the patient should be we can say the extubated in the OR if possible, and to determine if any deficit or the present that have been aggravated by the when you are doing that procedure. So if you think there is something is not good or not appropriate, then rapid reintubation and admission to the ICU overnight should be considered for, we can say, and for few hours, vitals, and we can say the neurological examination and further assessment of any changes noted immediately following surgery. So the counseling regarding the, we can say, the danger of the biopsy should be explained and very carefully to the patient, family, and the surgical cure is not the goal of or the option for us at the time of the hydrocephalus in the tissue. In this issue, the ventriculoperitoneal shunt or the endoscopic third ventriculostomy should be offered to, we can say the minimize the symptoms and allow to improve the little improvement for the quality of the life. As you know and as we know, this is definitely not a very promising kind of results for this kind of tumor. But I just wanted to present in front of you people so you could understand how it behaves and how it's all. So it is all in front of you. I hope you will like it. If you like it, please subscribe it, share it, and support us. Thank you so much. See you with another good lecture.